Man, woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP's cable television channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Hello, I'm Dr. David Morwood. I'm a plastic surgeon, and this is Your Health radio and television program. Thanks very much for being with us. I have three very special, three very intelligent, interesting guests today. And my very first guest, the distinguished Dr. Soteria Karahalios, cardiologist. Dr. Karahalios, thanks very much for joining us.
Thank you. It's a pleasure to be here.
Soteria Karahalios. I love that name. It's very musical, actually, isn't it?
It's Greek.
Well, it's a great name. Dr. Karahalios, thanks for joining us. Now, you are a cardiologist, and I want to talk a little bit about your average week, and I want to talk about some of your areas of interest in cardiology, because I know cardiology is a huge field, right? Now, tell me how you got interested in being a cardiologist.
Well, I was always interested in the sciences, and so I knew I was going to probably do something in science as I entered college, and started thinking more and more about medical school, and as just the years went by, decided to go ahead and apply to medical school. I was also thinking of doing some graduate work in physiology, and ended up doing a little bit of both for a while, and then just shifted over to just finishing medicine and progressing on in a field of medicine.
And Dr. Karahalios, where did you grow up?
I grew up here on the Monterey Peninsula.
Here in Monterey,
Yep.
And you went to medical school?
At UC San Francisco.
Oh, great.
Yep.
And you got the majority of your training in Los Angeles?
Yes, for residency and fellowship and private practice there as well.
Now, Dr. Karahalios, you know, I do have to mention that you have this connection to UCLA. And most of my viewers and listeners know I trained at USC. Now, had I seen that on your resume before, I may have thought twice about inviting you on. No, I'm just kidding. I know you're excellent and you're highly respected here in the community, and I appreciate you coming on the program.
Oh, thank you.
So, but during medical school and internship, you rotated through internal medicine and surgery and pediatrics and psychiatry. What was it about cardiology that attracted you?
Well, it was actually in my residency. I was going to do an endocrinology fellowship, which studies diabetes and metabolic disorders, and I did some graduate work in that field. But I had an attending physician in cardiology who really inspired me, and I really enjoyed it very much, and decided I wanted to change to cardiology, and that's how it happened.
It's a fascinating field and a huge field. And cardiology, it seems like it's in the press about every day.
Yes.
Now, tell me about your current work situation. Now, where are you working now?
I work at Community Hospital, and I'm the medical director there of non-invasive cardiology, which means I oversee the non-invasive studies, not angiograms. I used to do those in private practice in the past when I was practicing clinical cardiology, but this is a lot of the diagnostic studies that we do that assess people who have symptoms, chest pain, shortness of breath, palpitations, arrhythmias, and help determine as to whether they have heart disease, what the type or nature of their heart disease is, how severe it is, and in some cases, hopefully, it excludes that they have a significant heart problem. So it's the diagnostic testing that we do to determine if somebody needs, further what their further medical care should be, and if they need any kind of intervention.
Okay. Now, you mentioned chest pain, Dr. Karahalios. I know that many of our patients will tell us that when they experience chest pain, that's one of the most startling symptoms that a person can ever experience. Now, but it may not mean that it's heart disease. Isn't
That's
that
right.
correct?
That's right. Not all chest pain is related to heart disease or a heart attack. But it's the first thing and the most important thing that we want to evaluate and to exclude, that there's heart disease present. So if there's any doubt, we tell people to come to the emergency room quite quickly and promptly, especially if there's any history of risk factors that might predispose them to having heart disease.
Okay, now you are the director at Community Hospital of what division now? Of
Non-invasive cardiology or
non-invasive
cardiovascular. Right.
Okay, so what is invasive cardiology? Let's explain to our listeners and viewers the difference between non-invasive cardiology and invasive cardiology, if we could.
Invasive cardiology is using techniques like angiograms, performing heart catheterizations, or electrical studies like electrophysiology, where we actually go into an artery and vein and may have to inject dye and take pictures that will delineate or show us whether or not there's a significant problem with the arteries of the heart, let's say, or the electrical system of the heart. And then in addition to that, now with what we have is percutaneous interventions, that's also part of invasive cardiology. We can do balloon angioplasties where we inflate a balloon to open up a narrowing in an artery, or place a stent which will keep that artery open. So that's all invasive cardiology. Non-invasive relates to not going into an artery at all. It involves maybe doing a stress test, using ultrasound, which is non-invasive, to image the heart and determine if there's a valvular problem, if there is a problem with the heart muscle. Other imaging tests that are non-invasive are CT imaging, computed tomography, MRI or magnetic resonance imaging. Those are all non-invasive tests because we can image from the outside without injecting catheters, introducing catheters into the body to perform the test.
Well, it sounds like amazing new technology that you can actually get an idea of what's going on with the heart.
It is.
Without even passing instrumentation into the body.
Yes, and it's particularly important now because the forward progress of cardiology is in preventative cardiology and being able to detect disease early, because if you wait till someone has symptoms and they're in an emergency situation, often if it's a symptom of truly of heart disease, it often is late in the game. They have advanced disease and you're trying to prevent a crisis or a heart attack or a major event. So being able to detect disease early means you can intervene early and prevent progression of disease and hopefully prevent a heart attack or sudden death or a major event.
Okay, perfect. Now, Dr. Karahalios, that's a great segue into my next topic. Actually, I want to talk, in the very few minutes we have today, I want to talk about a couple things. I want to talk about the type of heart disease that you feel that we can actually prevent. In other words, there's different types of heart disease, right? There's valvular disease, there's coronary artery disease, there can be a problem with the muscle itself, right?
Right.
And then I'd like to talk about, if we have time, how we assess someone's risk. Like, how do they know they're at risk for heart disease? So let's address the first question. When we talk about preventing heart disease, what type of heart disease can we prevent?
Well, probably the one we should talk about, because there's not that much time, is coronary artery disease. That's the disease that affects our arteries, and it's actually an inflammatory process. It's inflammation in the lining of our arteries that nourish our heart muscle, and that is the process of atherosclerosis, where there is infiltration of cholesterol and buildup of plaque in our arteries that causes progressive occlusion or blockage of the artery. When there's a complete blockage, that's a heart attack, and that's when the heart muscle dies. And during that time, we can be prone to arrhythmias, serious arrhythmias that can also cause sudden death, as well as eventually heart failure. So these days, it's all about prevention of coronary artery disease, preventing heart attacks. It's the leading killer of men and women in the United States. And so I would say that would be the primary, focus of trying to look at prevention in that context.
Okay, now, so our listeners and viewers know, we just want to get clear. Now, the heart is responsible for pumping the blood to the body and to the lungs, but it needs blood itself. And just because it's being bathed in blood or pumping blood, it also needs to get blood to the actual muscle cells. Isn't
That's
that right?
right. The heart is one big muscle, and in order for it to function well and provide circulation to the head and the extremities and the organs and the kidneys and all of that, it needs to stay healthy, and so it needs the arteries that supply that heart muscle to remain as disease-free as possible.
Okay, so those coronary arteries are actually responsible for delivering the blood to the muscle of the heart itself.
That's right.
Okay, now when those arteries get inflamed, they can get occluded, partly occluded. Now, is that called
Right.
hardening of the arteries? Is that?
Not exactly. The process is atherosclerosis as opposed to arteriosclerosis, which is the hardening of the arteries that can happen in the other vessels that in the periphery. The process of atherosclerosis involves an inflammation. It also involves a deposition of cholesterol and lipid in the lining as well, and a scarring, which is what we call fibrosis, a process of healing and repair that can build up a fibrous tissue also that helps to contribute to the plaque, the buildup of plaque. It's a process that goes on for many, many years. It can start as early as in our teens, certainly in early adulthood, and it progresses to a different degree and a different rate depending on risk factors. The biggest one probably being genetics, family history or predisposition. In addition to that, the other primary risk factors are smoking. Diabetes is a major one. People who are diabetic are considered to having, a coronary artery disease equivalent because they have a higher incidence of vascular disease, and vascular disease in particular that can affect the coronary arteries. The other risk factors being high blood pressure and high cholesterol, or abnormalities in the lipid profile, the other fats in the blood.
So it sounds like it's a multifactorial. Actually, it's fairly complicated.
It is, and sometimes people have only one predominant risk factor. They don't need to have 4 or 5 risk factors. Obviously, if there are 4 or 5 risk factors, that multiplies the risk. And certain risk factors are more, have a higher degree of association of higher risk, as I said, diabetes. But sometimes it can be just one major risk factor, and it may be only family history. And sometimes that family history can affect certainly genetically determined lipid abnormalities. So when we look at cholesterol, we don't just look at the total cholesterol. What we really focus in on is the bad cholesterol, which is called LDL. And if that's high, we don't want it to be high. We want that to be lower. But also the HDL, which is the good cholesterol. And if that's too low, that is a subset of individuals that can have an increased risk, and that is often genetically transmitted or determined.
Now, I see. Now, does this coronary artery disease occur in all races, in Caucasians, in blacks, in Orientals? Does it occur equally in men and women? When or what decade does it predominantly occur in?
Well, it occurs in all populations. The Japanese seem to have a lower incidence that may relate to their high fish consumption. But if you look at certain populations, Hispanics have a clustering of risk factors. They have a higher incidence of hypertension, a higher incidence of diabetes, and a higher incidence of cholesterol. And if you have, again, as I said, multiple risk factors or a clustering of these risk factors, that increases the risk. Women tend to have an increased incidence of heart disease after menopause. So you usually see a delay, so there's a 10-year lag behind men, but it takes a precipitous rise right after menopause in that decade that follows. There are metabolic changes that occur in women with the decline in estrogen. Estrogen also keeps the good cholesterol, that HDL level, high, and that offers some protective effect in their 30s and 40s. And so as menopause occurs and estrogen falls, the HDL can also decline, and that can be one of the contributing factors that puts them at increased risk, in addition to weight gain often and other metabolic changes.
Well, that's fascinating. Now, Dr. Karahalios, let me give you a couple hypothetical patients, and I'd like to talk to you about how you would assess their risk. Let's say that we've got a 55-year-old man or a 60-year-old woman who knows that one or both of their parents died relatively young from heart disease, from coronary artery disease, and they were told that it was a heart attack. Let's say this man or this woman is totally asymptomatic, but they're interested in themselves. They want to know if they're at risk to having a heart attack. Now, is it possible for you to evaluate them? How would you go about assessing their risk?
That's an excellent clinical sort of picture of what we commonly are presented with. An asymptomatic person, positive family history in a primary relative, that means mom, dad, brother, sister, who had a heart attack at an early age being in their 50s for a woman, 60s or earlier for a man. So they may themselves, they may not have any other risk factors, but the first question is, are they symptomatic? And that means taking a good history sort of review of any issues. And do they exercise? Because if somebody's sedentary, they may not be stressing themselves to know that they are having symptoms. They may not be short of breath because they don't even go up a flight of stairs. So that's question number one. Are they truly asymptomatic? The second question is, do they have any other risk factors? That means, is their blood pressure? They might have been told or gone somewhere and had a blood pressure check 2 years ago and they were told it's okay, but it may not be okay. So do they have other risk factors? Do they smoke? Is their blood pressure higher than it should be? It may be, that may be an operant feature. And what is their lipid profile? If their good cholesterol is too low or their bad cholesterol, the LDL is too high, then they've got other risk factors. But that's the kind of person I would often look at doing something called a coronary artery calcium score. It's done by a CT scan. It's non-invasive. It takes about 10 minutes to do. You just lie under the CT scanner. It's a low dose of radiation relative to some of the other angiographic and CT angiogram studies that we do. And it measures the amount of calcified plaque. First, it detects whether there is calcified plaque in the coronary arteries and how much plaque there is. The higher the calcium score, the more the plaque. That means the more atherosclerosis, and the more the risk, the higher the risk. And that person may need subsequently to have some type of stress test, either a stress test perhaps with some imaging accompanying it, which makes the detection of the disease and the significance of the disease more specific. But further, if they don't have any significant narrowings, but they still have evidence of calcified plaque on that calcium score, what it guides is the intensity of the need for lipid-lowering therapy, for blood pressure medications. It dictates what the goal of getting that bad cholesterol, that LDL, down to.
Well, Dr. Karahalios, that's really fascinating, and I wish we had hours to talk about this stuff. I've got about less than a minute left. I've got a couple quick questions for you. For people who have more questions or who feel that they need a risk assessment, I want to give out your name, and I'd like to get, perhaps you have a number or a website. Dr. Soteria Karahalios, you're right here at Community Hospital Monterey.
Yes.
And now, how do people get an evaluation?
Well, if they're a woman, they can formally come to the Women's Cardiac Risk Assessment Program at CHOMP. 625-4765 is the number for that.
So I'm going to repeat that, 625-4765.
Right.
And how about men?
Right.
Can they call another number?
Men, yes. I also have a private practice with my partner, Dr. Terrence Moran, and who is a lipidologist, and he runs our lipid management program also at CHOMP. And we have a private practice of cardiology as well called Prima Heart.
Prima Heart, and that's in the phone book?
Yes, it can be located in that respect.
Dr. Karahalios, Soteria Karahalios, I just want to keep saying that name. It's so musical, like I said, cardiologist. And you are in charge of the non-invasive cardiology division here at Community Hospital. You're teaching me a lot, and I think our audience appreciates it. Thanks very much for coming, and I hope you come again.
Okay, thank you very much. Bye-bye, Dave.
I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to take a brief pause for a very good cause. We'll be right back.